My name is Mitch Belkin, and I'm here with my brother, Daniel Belkin. We're both radiology residents in Baltimore, Maryland. And today we're here with Dr. Ben Strong, who's Chief Medical Officer of vRad. He's board certified in both radiology and internal medicine, and previously worked as an emergency room physician for the Indian Health Service, and previously was a clinical assistant professor of radiology for the University of Arizona. Ben, welcome to the External Medicine Podcast.
Thanks very much, Mitch. Daniel, pleasure to be here.
Before we get started, do you have any financial disclosures?
Well, I'm nice and easy with regard to that. I have one job and one disclosure. I'm the Chief Medical Officer of Virtual Radiologic, which occupies all my time, attention, effort, and thought.
So you have a very interesting background for a radiologist. Not many radiologists did internal medicine and worked as an emergency room physician for a while. We want to get into a lot of other stuff about radiology, but before we get there, can you tell us a little bit about your background and how you came to find your way to radiology?
Yeah, it was a roundabout way. In fact, residents ask me all the time, should I do that? Should I do a medicine residency first? And my answer is always, I am glad almost every day that I did it, but I would recommend it to no one. It was a long time getting out of training, ultimately. I was in postgraduate training for 9 years. And true story, when I called my mother to say I was doing a fellowship in body and MSK-MR for my 9th postgraduate year, she cried. She broke down and said, I don't think you'll ever get a real job. And it was quite a scene. So I basically always wanted to be a doctor. And I mean, from the time I was 5. And ultimately, when I was getting ready to graduate from medical school, I did fill out 14 radiology applications, and I was dead set on going to radiology. And I was actually shamed into doing internal medicine because I called around to my old attendings for reference letters, and I got things like, gosh, Ben, I always thought you'd be a real doctor, or, oh, what a disappointment. I mean, they were really
scathing
and harsh. And I actually took that to heart, and I thought, you know, if I were walking down the street and saw some guy clutch his chest and faceplant, I wouldn't have any idea what to do. And that was the essence of being a doctor to me, was being able to handle situations like that. I said I wasn't going to be that guy on the plane that shrunk down and covered his face when they called for a doctor. The truth is, I underestimated the value of my internship, because by the time I was done with my internship, I really did feel pretty competent. And at that point, I had sunk enough time and effort in that I figured I would just finish the internal medicine residency. But I really did know that I'd be going on to a second residency, even in my second year of internal medicine.
So eventually you saw the light or the dark.
Or the contrast.
You saw the contrast, 5 shades, and you became a radiologist. And so what prompted, like, how did you end up at vRads?
That was very interesting. Well, I truly loved radiology. It stemmed originally from a love of anatomy. That was what really attracted me to medicine at first, and then ultimately to radiology. I thought when I was starting medical school, I was certain I would be a surgeon. And people would tell me in my medical school class, they would tell me, oh, I don't want to do surgery. And I would always think, well, that's only because you can't. If you were going to be a doctor, you would be a surgeon. That just seemed obvious to me. And the funny thing was, in my 3rd year, I did my surgery rotation and discovered on my first day that I hated it. As soon as I got into an OR and all dressed up in my sterile garb, I immediately felt this burning need to scratch my nose, to eat something, to drink something, to go to the bathroom all at once. and found that I was kind of a creature comfort guy that was never going to fly in surgery. So that's when I finally started looking at radiology seriously as an application of my love of anatomy. I actually didn't even know radiologists were a specialty. I didn't know it was a thing. In fact, I remember our first radiology lecture when I was in medical school. We had a radiologist up there showing x-rays, and finally it hit me. And I turned to my friend who was my source for medical information. He had been a nurse before medical school. And I said, "Are you serious? That's all this guy does is look at x-rays?" And my friend said, "Oh yeah, he's a radiologist." And I sat back, folded my arms on my chest and said, "I don't know who is going to pay you to do that." I mean, it didn't even seem like it could be a real job. But ultimately, it was my love of anatomy that drove me to it. And I took the long way around. But once I entered radiology, I knew I was where I belonged, no question. The thing then was that I was driven by a love of radiology. I just wanted to do it and more of it, as much of it as I could. And the workflow in radiology was abysmal, just terrible. I actually started just reading actual plain films or films hung on alternators. My first year in residency, it was all alternator-based x-rays. And then by the time I graduated, it was all PACS. And so I lived through that transition. And basically, I still remember I was a medicine resident. The first time that I saw an x-ray on a computer screen. And many people, it was just a JPEG from the internet. And, when someone sees for the first time an x-ray on a computer screen, many people have different thoughts. There are a lot of thoughts about access and archiving and just the logistics of radiology that are immediately apparent. But my first thought was, I won't have to go to a hospital. There's no question that was the first thought I had upon seeing an x-ray on a computer screen. And I was thrilled at that prospect. But then, of course, through my radiology residency, that was out of the question. No one even was considering it at that time. When I came out of training, I basically set the rule for myself. I'm not crossing the Mississippi to the east, and I'm not going to read a backlit film. I'm going to find that practice in the Western US that will offer me 100% digital reading. And there was really only one practice that fit the bill. And so I went to Inland Imaging, was the practice in Spokane, Washington. And they were covering a fairly large rural spread of small towns and were purely digital. And they did keep their promise to me. I read only on a computer. But that still was not enough. They had committed the foul that so many radiology practices did at that time. They were digital, but they had used digital technology to replicate the old analog workflow. And so even though you were on a computer, you still had paperwork before you that you would scan in to bring up a case. You still had a transcriptionist dictaphone that you dictated into. And it was horribly inefficient. You could see a glimmer here and there where you could imagine just doing nothing but radiology, but it was clearly far in the future. And every day I would pack up my favorite mouse into my jacket pocket. And because if I left a mouse anywhere, it would be stolen. And you were at a different place, a different facility every day. And so I had to pack my mouse with me. And I would walk out of the house. And as I did, I would pass my office in my house where there was a fully capable workstation sitting there, where oftentimes one of my colleagues would have called me at midnight the night before and asked me to review a case for him. And yet it was good enough for that. But every day when I left the house, I looked longingly at that fully functional workstation and thought, why do I have to drive across town with my mouse in my pocket and work at a random desk in a random basement when I've got the capability right here? And so that was really the driver. It was the irritation at workflow inefficiency and the fact that it was clearly entirely possible to read studies remotely at that point. My frustration with the workflow cannot be overstated. I actually used to cross the threshold of any given hospital each morning, and I would think to myself, what'll it be today? How will inconsistent systems, how will personal selfishness, greed, incompetence all conspire today to prevent me from reading a radiology study? It really felt like it was me against the world. And so those were the concerns I had. And I went online just looking for a teleradiology practice. And there were a few, actually, there were quite a few, but they were all really small and they were all kind of cobbled together from a technology standpoint. And vRad somehow really stood out. When I went and visited, I was really impressed with the corporate culture, with their emphasis on technology, and ultimately chose them over all others. I was about the 25th radiologist to join vRad.
And so this would have been in the early 2000s, right?
Yeah. About 2004 was when I signed with vRad, and I'd been out since 2001. So everything after that is history. vRad now has 533 radiologists, covers about 1,600 hospitals nationwide, worldwide, really, and reads about 6.7 million studies a year.
Just to clarify, in your resume, it mentions that you worked as a clinical assistant professor of radiology. Was that while you were simultaneously at vRad, while you were at the private practice, or where did that come into the picture?
It was in my transition to vRad. There's a 6-month period typically for you to get sufficient state licenses and hospital credentials to have a full queue in a teleradiology practice. And so that time, plus there was a bit of overlap between my assistant professorship and my early days at vRad.
How did you get interested in QA? I feel like QA, which for anyone who doesn't know is quality assurance, is like the most boring name for one of the most interesting facets of medical care. In fact, there was actually a QA conference at work today, and so this would fall into the category things that fall maybe define QA and what sorts of things fall into it and that category, and tell us how you got interested in it.
The bottom line was that vRad asked if I would join the QA committee, and I was absolutely honored and flattered, and didn't necessarily know that much about it or see what would come from it at the time. But quality assurance basically is the process by which we overread one another. You know, radiology is unique among specialties. Well, not perhaps unique. Pathology is similar, right? In that there is a permanent record of the patient interaction. And so a review can yield a great deal of insight. It's very different, say, than going through charts for an ER physician and trying to take exception with something they've written there, right? Because there's no longer a permanent record. The patient's not there, the lungs can't be auscultated, et cetera. But with radiology, it's right there for all to see. And so in implementing QA, it was the early days of teleradiology, and it was extremely important that we maintain accuracy in our interpretations. That was something that was, a bit of a challenge. In the earliest days of teleradiology, people loved to denigrate it and say, oh, that's the bottom of the barrel. Those guys can't get jobs anywhere else. Obviously, all of that has changed. It's been 20 years, and it's very widely accepted as probably the best way to do radiology. But at the time, we knew we were struggling against this sort of unearned reputation, and therefore focused very strongly on quality assurance. So we developed our own system of classifying errors and of overreading our own radiologists. And it was truly spectacular. We did a lot of preliminary reads. 20 years ago, it was logistically very difficult to get a seamless and complete integration with client facilities. We couldn't always see the entire imaging timeline. We couldn't actually enroll all of our providers in regional payer networks. And because of that, it was 100% preliminary after hours emergency radiology in the early days of teleradiology. That was the niche that we clearly fit. Now, of course, we've overcome all those obstacles. We have complete visibility into patient timelines. We have all our radiologists enrolled with regional payers. And so over the last 20 years, we have shifted from 100% preliminary to only about 20% preliminary, and that diminishes every year. So the reason I bring that up is that in the early days of vRad, 100% preliminary, the arrangement was that the next day, the on-site radiologist would come into work and see a list of the studies vRad had read that previous night. And they would overread those studies, issue a final report, and then submit that for billing. So needless to say, there is an automatic, inherent second reading done in that situation. And vRad went to great pains to capture any discrepancies that might have arisen between those two reports. So we created a portal that allowed on-site radiologists to submit when they thought that there had been an error. So we had a constant, free, inherent overreading capability that most people could not have availed themselves of. And the QA committee basically took in those submissions from around the country, reviewed them, coded them according to severity, and then communicated that conclusion back to the on-site radiologist as well as to our own. And it was a truly extraordinary experience, that reading for facilities across the country and seeing these overread studies with errors be submitted to you. And so in my early days, especially on the QA committee, my eyes would bulge out of my head with every case I opened. Oh my God, I would have missed that too. And so it was really an intense learning experience. And that experience actually informed our current actions, because now we take quality assurance data. We also do internal overreading as well now, because our percentage of preliminaries has dropped. But we take that information and we use it. We actually recycle it and put it back into the system, closing the loop essentially by using quality assurance cases as the content for our CME presentations. I use medical malpractice cases in much the same way. And so it is something that we have done for 20 years or more and have built into a lot of our systems. In fact, we've been building artificial intelligence algorithms, and the artificial intelligence algorithms that we choose to build for specific pathologies are also based on that kind of data. We know what are the most commonly missed entities in radiology, and we know what are the most expensive or disastrous misses that might lead to medical malpractice cases.
This perfectly leads into your 137 years of medical malpractice YouTube series, which we will link to in the show notes for anyone who is interested in this particular topic. I thought that this was extremely interesting to actually see in real time the cases where things were missed. And you kind of go into great detail, and we'll dive into this into some depth as to the sorts of cases that were the cause of misses, major miss rates, and lawsuits that have resulted. But to just kind of get a general overview, it seems like you ended up on this QA committee. What led you to then decide, you know what, I want to focus more closely and dive into like medical malpractice specifically, and then to present this very nice YouTube series?
Well, that actually arose from some complaints about the management of medical malpractice cases. It was kind of, so we have had any number, well, 7 parent corporations in the time I've been at vRad. vRad is frequently bought and sold, or at least has been in the past. And one of our parent entities complained to me that your medical malpractice costs are too high. We want you to fix it. And I said, well, give me the data. I mean, I need to know what we need to fix. And they actually were very reluctant to part with it. In fact, the first spreadsheet that they sent me was a list of patients and cases and a column where it had been categorized, at least in their minds. And the entire column read diagnostic error, diagnostic error, diagnostic error.
Very
And
helpful.
I said, what am I supposed to do with this? I mean, that's fairly obvious, right? And so at that point, I insisted, I need all the images, I need all the reports, I need all the depositions, I need the reports of counsel, I need every document associated with these cases. And that was what pretty much decided me that this is where we're going. And each of the cases in that presentation, ultimately, I went through 45, which was about 4 years worth of medical malpractice cases. Obviously, a practice of our size can generate, unfortunately, a healthy number of those. And so I went through each of those 45 cases, amassed all the documentation we could on each one of them. And most of them took at least a day, some of them all of 2 days to review. When you ask for deposition documents, you're going to get a stack thousands of pages high sometimes. So it was just that driver that here was this extraordinary expense that we wanted to get a handle on. And the way to do it was obviously a very in-depth, detailed review.
So you're getting these depositions, you're actually looking through them. And I guess I'm sort of curious for, you're being told that medical malpractice is a huge cost to the overriding organization. How do you go about trying to figure out if that is or isn't the case? You use a term called the major miss rate of cases, and you say, vRad's average major miss rate is a certain number. Compare that to an ER, compare that to a trauma center, and you come up with different numbers. How do you determine what is a appropriate major miss rate, and what even counts as a major miss?
Well, that all stems back to our early work with QA. We basically went and classified misses as major, minor, and essentially minimal, I guess we would call it. It's usually technical factors, voice recognition, typos, things of that nature go in that bottom category. And we based it on the severity of the pathology and its impact on immediate patient management. So it is a little bit emergency teleradiology in its orientation. A major miss is, just like it sounds, something that needs to be addressed, usually that night or in the very near future. Things like, well, just about everything you can imagine that's serious. Everything from strokes and intracranial hemorrhages to acute appendicitis, bowel obstructions, bowel perforations, pulmonary emboli, all of those sorts of things are major misses. Minors are where we're unable to determine the severity, say an non-specific renal lesion that might need follow-up, but isn't necessarily a cancer. Things of that nature that are more nuanced and less impactful with regard to acute patient care. So really the acceptable level of major miss rate, we've come to that conclusion based on our historical data. We've been doing this for more than 20 years now. We know our average major miss rate for the practice, and we know where things are just getting out of hand, right? So our average major miss rate is about 1.3 misses per thousand, which is actually very good. When we compare that to other published rates, it's probably about a third as many errors as, say, the Wilson-Wong study, which is probably the largest that you'll see published. And that was based on 126,000 overread studies, whereas we're generating probably 1 million overread studies every year. So we're very confident in our data, in our statistics, and in that major miss rate. And the interesting thing was that we have that for all of our radiologists. And so we could look at 45 medical malpractice cases and actually know the radiologist involved and tie that to their major miss rates. So one of the many parameters we looked at. And what we did find is that there really was no correlation. In fact, 2/3 of the radiologists involved in that case, in that set of cases, had lower than average major miss rates, lower than the practice average. So it showed you that there is an element of bad luck involved here as well. Right? I always tell people there are 3 things that have to happen for a medical malpractice case. There has to be a legitimate radiologist error. There has to be an inattentive clinician. Maybe that's too harsh a word to use, but a clinician who fails to piece together that, hey, this whole picture is still not making sense. How can I be looking at this clinically and have this radiology report that says everything is fine? There are those clinicians that say, hey, I'm going to get this looked at again. I'm going to reconsider this in the light of the fact that I know that there are errors in radiology. And the third thing that's required is a devastating patient outcome. You really don't see medical malpractice cases in situations where there was no significant injury to the patient. So you have to have, they're kind of like the wheels of a slot machine. They all have to come up lemons in order for a case to become a medical malpractice case.
That's a perfect segue to the types of lawsuits, or rather, not only the types of lawsuits, but what types of actual studies are the ones that tend to become lawsuits. And I mean, granted, for the number of cases that vRads or any large entity is reading, 45 is just such a small number of lawsuits. I'm assuming that the vast majority of cases are that do have a major miss that did result in a complication are settled, and those are excluded from this analysis, correct?
No, those were all cases that went to settlement, what in the industry parlance is called an indemnity. And so if it costs you anything above and beyond legal costs, that's basically referred to as an indemnity. And the vast majority, vast majority are settled. But if any case that resulted in an indemnity, that was the criterion I used to include it in my analysis. So the trends were very interesting. One thing going in, I thought, I bet a lot of this is communication, right? The failure to call a clinician directly and verbally report a critical finding, I bet that's a big problem. In fact, I was guessing at it and thought maybe a third, maybe even more than that, will be due to some kind of logistics or communications glitch as opposed to an actual reading error. And I discovered that was, in fact, not the case. It may be the case in other practices. I do have to say that vRad has a very sophisticated communication system where I can get a referring clinician on the phone with a single click of my mouse. All the communication systems are built in. We have an integrated auto dialer in our system. And so I don't even have to dial a phone to discuss anything with a clinician. And all of that gets automatically digitally timestamped and recorded for auditing purposes. So I think because we had all that so well locked down, it turned out there were very few such cases. There were 5 where communications was actually an issue in the primary issue in a case becoming a med mal. And of those 5, it was interesting, there were really only 2 that were specifically that scenario where the radiologist saw the finding, put it in his report, and then failed to call the referring clinician. There were really only 2 out of 45 cases. The other 3 were just variations sort of on that theme, including one voice recognition typo, the only one in the group. So that's 1/9, 11% of all the cases really could be tracked back to a communications glitch. Then there was another 9th where the radiologist did absolutely nothing wrong. Perfect report, succinct description of the finding that was in fact there, and yet an indemnity ultimately was paid out. And that's usually because of the legal machinations in any given case. Defense lawyers are particularly averse to being the only person left at the table. So oftentimes in med mal cases, they will go around and really just name in the suit everyone that had any contact with that patient, right? The ER physician, the admitting physician in internal medicine or whatever service it might have been, the radiologist, the pathologist. Sometimes they even go after nurses and techs that are in that chain as well. And what happens is when threatened with a lawsuit, most people's immediate response is to settle. And once all those people sitting at the table with you have settled out, the defense lawyers, again, are very averse to having you be the one person at that table at trial. So that's how the 5 radiologists that really did nothing wrong, no error, good report, good communication, still get hit with an indemnity. And that does happen. So that was 11% of our cases as well. The other thing, since we were talking about the MMR, I had mentioned that 2/3 of them were actually under our average miss rate. So from there, we're left with 7/9 or 77% of cases that were diagnostic errors, where there was a life-threatening finding visible on the films and the radiologist failed to identify and report it. The vast majority of cases are on CT.
Yeah, sorry, go ahead.
Yeah, we read a lot of CT. I mean, we read more than a typical practice. We're up around 55% CT, about 30% X-ray, and about 10% ultrasound with just single-digit percentages of MR. It reflects basically the modality mix of emergency medicine. So the CT of the abdomen and pelvis, far and away the greatest med mal risk. If you think about all the organs that are represented in a scan like that, it really stands to reason.
Yeah, my first thought when you said that it was mostly CT and mostly CT of the abdomen and pelvis is this because CT is more dangerous from a legal perspective, or is it just that sicker people are getting CTs? And so by virtue of that sort of higher pretest probability, you're going to end up with more people who where you can miss something getting seen on CT.
That is a good thought, Daniel, although I don't think CTs are ordered with that level of discrimination that you suggest. They're done pretty widespread and with a pretty low threshold. So I think it's more about the complexity the number of organ systems that are represented in a CT, and the fine detail that's visible that can still be, of course, very significant. So I really think it's more due to those factors.
Can you tell us a little bit about the different actual like cases that you explore? Maybe the like what studies are most likely to end up in a paid malpractice suit, and I don't know, any interesting details of the individual cases that you could share for someone who is wants to listen to the 137 years of malpractice suits on YouTube, but they're just starting with this podcast.
Right, absolutely. Well, you definitely can identify trends, specific pathologies that are most likely to lead to med mals when missed. And we picked 3 out of the med mal that are clear outliers. And then actually, when we built our artificial intelligence algorithms, we added the 2 most commonly missed things through our QA system. And so we refer to those as the big 5. And those were the first 5 artificial intelligence algorithms that we built. But the 3 big ones from a med mal standpoint, the winner is superior mesenteric artery occlusion. It doesn't make it reliably onto every radiologist's search pattern for some reason. And that's another discussion, but I do think that search pattern is insufficiently emphasized in most training programs. And it's something that we built our whole system around, both of education and technology, is the concept of allowing a radiologist to adhere to their search pattern. And there's nowhere that I see that more an issue than in the superior mesenteric artery occlusion. So for the clinicians listening, that's one to know. That is one of the most frequently missed entities when present. A radiologist, some of our runs on the data have shown that a radiologist may miss that as often as 30% of the time when there is an actual occlusion of the SMA.
And that's not coming from the data on lawsuits. That's just period.
That's all of our data is suggesting that.
Wow.
Sorry, I'm curious. Is this just you think because people are? This is to get more into the radiology weeds, but is this because you think people are really only looking at these axially? Because I feel like if you look at sagittal reconstructions on a well-timed CT, like it's very clear on the sagittal reconstructions if you see the celiac and you don't see something below it. Like, are people just looking at these axially? Have you actually looked at how people are doing their own search pattern and which tend to miss or not miss the SMA occlusions?
Well, the axial images are enough for me, Mitch. I think it shows, it's a nice white circle there if it's okay. It is strange, but I always say for a radiologist to make a finding on a CT scan, think about all that is required. You have to have it on the right window setting. You have to be looking at the right structure with the right thought in your head, scrolling at the appropriate speed. And that's a lot to have come together. And it only really comes together reliably and repeatedly when people are sticking to a search pattern. And so ultimately, even going back to my work with the QA committee, I came away firmly convinced that 90% of all the errors I had seen were a failure to adhere to a search pattern. Many times when we would show a radiologist a miss the following day, they would say, well, I never saw that. I never saw these images. I would have clearly seen that. It's obvious, right? But in the heat of the moment, if you're not adhering to a search pattern and actively, cognitively adhering to a search pattern, you're going to miss things and sometimes even embarrassing things. And the real problem with superior mesenteric artery occlusions, especially, is not only that they're frequently missed, that it's not on everyone's search pattern, but also the kind of damages that it creates. Most of these cause large-scale bowel ischemia that result in extensive resections of the small bowel, and often happen to younger people. And so it really sets things up for a very expensive remainder of that patient's life. And that's why they tend to be very high in terms of awards as well.
I think we derailed you from other interesting facets from looking through.
So, well, that's the superior mesenteric artery. And actually, for the radiologists listening, I will tell you the other thing that contributes to SMAO misses, and that is the secondary findings that are usually present. Most superior mesenteric artery occlusions are due to embolization. And in all the cases where that had happened, there were additional microembolic infarcts in the spleen or in the kidneys. And so in all my educational content now, I really harp on that. When you see hypodense, well-demarcated, wedge-shaped lesions in a subcapsular distribution in the spleen or in the kidneys, go to the SMA and look, because it will be included in that embolic shower that came from somewhere upstream, be it an aortic or a cardiac source. And so that was kind of a disappointment to see that people weren't queuing on those secondary findings, which should have led them to the superior mesenteric. The other big thing about superior mesenteric artery misses is that it is also associated with bariatric surgeries, weight loss surgeries, stomach staplings with bowel relocations. You know, they will cut your proximal jejunum and basically create an afferent and an efferent loop, and they plug that distal aspect of the cut jejunum into the channel they've created in the stapled stomach. So it bypasses the stomach and all of the proximal small bowel. And when they do that, it disrupts all the peritoneal reflections, the normal restraints on bowel motility. And so your bowel is able to writhe and roil without the typical physical restrictions that a normally formed abdomen would have. And that allows them to suffer volvulus and all kinds of related complications that often will cut off the SMA. And so that's the second most common setting in which we see SMA occlusions. And so it's my advice to anyone ordering CTs or reading them that if you have a patient who has had a previous bariatric surgery, that study should be done with oral and intravenous contrast because of the wide variety of complications that those patients can suffer. They don't just get SMA occlusions, but that is, of course, the most devastating of the complications they can get. Those are my things on SMA occlusion. Look for the splenic and renal manifestations of an embolic shower. Use those to make you look at that SMA even closer than you would have. And secondly, with bariatric surgeries, have a very low threshold for calling things abnormal. And basically, if I see a non-contrast study on a bariatric patient, I send it back. I call the clinician and say, this needs to be repeated with contrast. So those are my takeaways on the SMAO. The next big one, I would say, is aortic dissection. And aortic dissection it frequently results in stroke and death if it goes untreated. You have a relatively narrow window in which to address that. And I think the rapidity with which that pathology can progress is the real reason that we see it so prominently in our list of medical malpractice cases. So my advice on that is look at the aorta every single time. The interesting thing about the aortic cases was that I think I had 5 of them in that sample. Of the 5 cases that there were, only one was appropriately performed with aortic contrast, a CTA of the chest with the contrast column in the aorta for analysis for aortic dissection. All of the other ones were cases where there was no clinical history suggesting it, where the study done was not optimally protocoled or even positioned anatomically for analysis of the aorta. So we had one that was a PE study where all the contrast was in the pulmonary artery. We had one that was a flank pain, just a routine abdomen pelvis CT. We had one that was a non-contrast CT of the neck, and yet still you could see the flap in the aortic arch at the very bottom of the study. So my advice to all is look at the aorta, no matter how it's protocoled or where it is positioned anatomically in your scan, or what the clinical history is. The aorta heads my search pattern on everything I look at. If there is aorta on that study, I look at it first and most diligently. So that's aortic dissection. The third one is the spinal epidural abscess. And those are tricky, and it is worth pointing out, it's the abscesses that go south. Many of the hematomas that I've seen, those oftentimes can resolve without surgery, but there's no way a spinal epidural abscess is going to go away without appropriate treatment. And they tend to be hypodense as opposed to hematoma in the spinal canal. And so that makes them even harder to identify. Also, you do a lot of neck and certainly cervical spine imaging without contrast. So that's a further impediment to accurate diagnosis. The thing about the epidurals, the spinal epidural abscess, it's kind of similar to the superior mesenteric artery issue, where there are almost always secondary signs that should direct your attention to the spinal canal, to the possibility of an infectious process. Most of the spinal epidural abscesses that I have seen missed have an original extraspinous source of infection. So one was a facet joint infection, one was a tonsillitis, one was just prevertebral edema that was most likely infectious bacterial pharyngitis. But all of those should be warning signs to you that I need to take a very detailed look at the spinal canal. So that's the big one on spinal epidural abscess. I think take as a cue any evidence of an infectious process anywhere in the extraspinous tissues, and let that be a warning to you that I'd better go check that canal again.
I have a follow-up question to the spinal epidural abscess. On the specific cases, I know those two particular cases are very interesting, with the prevertebral soft tissue swelling and the facet joint being very, very, very prominent. But of course, a CT, I think in this case, one of them was non-contrast, or perhaps even both of them were non-contrast CTs, would have been sufficient from a medical legal standpoint to say, for further evaluation, if there's clinical concern for spinal epidural abscess, recommend evaluation with MRI. Or did the finding, is mentioning it in the report sufficient to shield legal liability, or no? Because there is an image which, if you really window it enough, somebody can squint and see it, that you're toast.
Yeah, that's a great point. And generally speaking, if you can see the finding, you're probably going to be held liable. And that was, they can find experts to say anything. If you remember the CT of the neck where the aortic dissection was missed, there was a deposition statement from one of the plaintiff's experts that said, I don't see what the big deal is. A non-contrast CT scan of the neck is perfectly adequate for the identification of an aortic dissection. Which, of course, is a ridiculous statement. But again, you can find an expert to say just about anything. But you do bring up another good point, which is the use of boilerplate disclaimers. And that is something we really discourage, because it does not provide you with any kind of legal liability mitigation. So, and I am saying, these broad disclaimers that you hear people put in their reports all the time. Absence of intravenous contrast makes identification of nonspecific lesions in the solid organs difficult. Something like that, right? That will never help in court. What will help is if you note a specific deficiency in any given study and make a specific recommendation to address it. So if you are looking at a liver on a non-contrast scan and things don't just look right, or you think maybe there is a lesion there, you don't give a boilerplate disclaimer. You say specifically, there is an ill-defined hypodensity of uncertain significance in the right liver lobe. I recommend a repeat study with contrast. If you give them a concrete directive that they then fail to follow through on, that will help you. That will mitigate your legal risk. But just spitting out these generic disclaimers that aren't citing anything specific to that study and aren't making a specific forceful recommendation, those will not help.
What about something that is a step below recommend? So it's like consider, CT abdomen pelvis with, venous phase for further evaluation if clinically indicated. Like, is that just because it's not quite saying do this, not enough?
I think once I've crossed the line into I think I need this, I'm usually pretty forceful and just use recommend. Because anything less than that, than a specific directive, obviously can be picked at by the plaintiff counsel.
Was there anything else surprising about going through all of this data in such detail that you didn't really expect, or that you feel like would be valuable for a radiologist working in this field to be aware of as they read that next CT abdomen pelvis or CT head or whatever?
Absolutely. Well, there were a lot. It was fascinating to do this. And actually, I'm well into my second set of 40 cases for the next 4 years. So I'm seeing, honestly, we had a big enough sample that the trends I spotted initially are still playing out and are consistent. So that actually has been nice to see that initial sampling was enough to come to correct conclusions that I now see borne out. One of the other interesting things that I noted, though, was the average duration of a medical malpractice proceeding. And that is 36 months from the time that a claim is issued to the time an indemnity is paid. The average is 36 months, and our longest was 7 years. So I tell the radiologist, and I'm sure that this is the case with all other clinicians that are involved in a medical malpractice proceeding. I talk to people frequently that say, this is the worst. It's just beating me down. My morale is in the pits. I can't eat. I can't sleep. I'm frustrated at small things. It really affects people's psyches. And I hasten to tell them, look, you need to get over it. You need to tell yourself this is not your money, that this happens to everybody. And you just need to find some way to get past it, because the average duration of a proceeding is 36 months. You can't go 36 months without eating or sleeping. That's just not going to be sustainable. So that, I think, helps calm everyone down a great deal. So yeah, that was one trend I noted. I guess the other thing, the other side of the coin from the QA, the average QA that we saw in medical malpractice involvement, the average productivity also doesn't seem to actually correlate with the likelihood of being sued. And that is just an interesting fact that I've noted for a long time, that there is no absolute number, and we're talking about productivity of how many studies or work units a radiologist reads in a given hour. The interesting thing about that is there is no absolute number of studies per hour at which every radiologist can be expected to see a deterioration in the accuracy of their reports. You would like to think that as soon as any radiologist gets going faster than 20 an hour, everything just unravels, right? And that's really not the case. What is the case is that every radiologist has his or her own number where their accuracy deteriorates. But that number could be 5 for some radiologists, and it could be 30 for others. And so the absolute number of productivity, we learned a long time ago based on our QA data that there's no reason to raise your eyebrows at 20 reads an hour when that person's major miss rate remains low. Right. So it's a common misconception in radiology, and I think in the world in general, that if you do something faster, you do it less well. And it doesn't seem to be the case. In fact, some of our most productive radiologists apparently get that way because of their regimented adherence to a search pattern. Right? There's a lot less hemming and hawing and hand-wringing over any given case when you know you have adhered absolutely to your search pattern and you know you're done. Right? And so it makes for very efficient reading, but also more accurate reading. So I found that to be very interesting, that there's so many other contributing factors that the quality assurance statistics or miss rates of radiologists doesn't seem to be a predictor. And similarly, the productive radiologists don't seem to be at particular risk either. In fact, about 2/3 of all the cases that I reviewed, the radiologist involved had a lower than average productivity rate as well. The QA misses that we found, the most frequently missed entities, probably because they're much more common than the 3 I mentioned for MedMal, but intracranial hemorrhage and pulmonary embolism. So for the clinicians listening, if something's not quite making sense and you were considering one of those entities, have that case read again.
In your YouTube series, you mentioned that there are some states based off of vRad data that are less favorable from a medico-legal liability standpoint. You specifically mentioned that New Mexico, New Jersey, Pennsylvania, obviously you're reading different amounts of cases from different states, and that does not include every single state.
It does, actually. I mean, we're in all 50 states. And what we did to create those numbers, the relative risk ratio for each state, is we divided the MedMal cost in that state by the percentage of, I actually took the percentages. So I took the percentage of our MedMal expense that originated from that state, and then divided it by the percentage of our volume that came from that state. So it was adjusted for volume. And you're right in that there were not cases from every state, but we have volume for every state. So they were all included in that assessment.
I see.
And there's no question that state by state, there's a great deal of variation. And Pennsylvania came in far and away at the top. I will say in this second round of analysis that I'm doing, New York was really making a run for that top spot this time around. And they had not finished so terribly high in the first analysis that I did. New York probably reputationally is considered to be the worst. It's certain that looks as though it's playing out in my second round of analysis. But then just when I was thinking that, Pennsylvania came in with a new law suspending the rules of venue in the state. And that actually was the problem with New Mexico. That's why it made the top risk states list in the first round, is New Mexico also suspended the typical rules for venue selection, meaning that typically when you file a malpractice claim, that will be tried in the region, in the county or city where the malpractice took place, where the patient resided. New Mexico suspended those rules and basically said, you can sue someone in any city in New Mexico. You name your venue when you file your claim. And so what every plaintiff lawyer in the state of New Mexico did was immediately start filing in Santa Fe. And so I haven't seen a New Mexico case that wasn't tried in Santa Fe. They go after the more affluent, the more educated, the more liberal regions because they tend to give larger jury awards. And so I was looking at New York and I was thinking this second round, New York is going to be the top spot. And then Pennsylvania came in with a similar law to New Mexico's. And so now I guarantee you every med mal case that originates in Pennsylvania is going to be tried in Philadelphia.
Good to know. on the flip side of maybe if you're equally choosing between, say, Pennsylvania and a surrounding state like West Virginia or Virginia, are there any states from your research that are particularly favorable to radiologists from a medical liability standpoint?
Well, certainly there were probably 25, maybe even 30 states where we had no med mal. No cases whatsoever. And certainly of those where there were cases, Texas came in very near the bottom because I guess what I would say is the states with caps on awards, if you are really looking to avoid med mal risk, those are the states to go to because it's the runaway verdict that really strikes the fear of God into defense counsel. The possibility that someone could be awarded 30, 40, $50 million, and that does happen. But those states where there is a cap on the possible med mal awards, those prevent that completely. And so I would say if I were looking at one parameter to choose the state in which I worked, it would probably be that. And I know Texas has those caps, but there are several other states that do as well.
And this is a write-in question, which was, there are some individuals who, in order to reduce the risk of being sued, may decide to have less legal liability coverage, since that is something that malpractice lawyers can see. If you're like, what are your general thoughts on having less coverage in order to try to avoid legal lawsuits? And then I guess the corollary to that would be, if your coverage isn't sufficient for a suit, can you personally become bankrupt?
Those are great questions. I mean, the bottom line is you don't want too little and you don't want too much. Having too much really is just a matter of your own expense, right? You have to pay for that policy and they're more expensive when you have a higher limit. Striking that balance is definitely the challenge. You don't want to be underinsured. However, it's not as big a risk as you might think. The vast majority of these, and so, right, don't go for the highest possible coverage you can get. I would say don't go for the lowest, but you can actually default to kind of the lower end of the spectrum in terms of actual coverage. The reason I say that is that basically all of these plaintiff lawyers, they will eventually come in at a policy limit demand. And that's been explained. So they will basically insist that you pay the limit of your policy. They very rarely go over that. And in fact, I haven't even seen it. What you will see is a histrionic, ridiculous initial demand. When plaintiffs file their claims, they will sometimes put an initial demand in there and they'll scream for their $30 million or what have you. And many doctors, they see that initial demand and they just become apoplectic and think, oh my God, it's all on the line. Well, that is nothing but posturing. nobody expects that they're actually going to get that unless there are just egregious circumstances surrounding the case. And what happens every time is through the normal course of the processing of that claim, that will be reduced to a policy limit demand. And that was explained to me by one of the particularly sharp lawyers I work with, who said, these plaintiff lawyers are not interested in becoming collection agencies. They are not going to go after anything that's hard to get, that being personal assets, right? Or anything above the medical malpractice policy limit. And I have seen that borne out time and time again. So if you have a high limit policy, they're going to demand that. If you have a reasonable but lower limit policy, they're going to demand that. And so I think going to the highest end of available medical malpractice coverage is probably not necessary. Now, to the issue of personal assets, I have never seen a physician have to pay from their personal assets for a medical malpractice settlement. And a lot of that has to do with the fact that the policy limit demand is just so standard in this industry. The other thing is that you really have to have, again, egregious circumstances. One of the lawyers I work with said, that guy, Dr. Death down in Texas, who was literally mutilating people, maybe they could have come after his personal assets, but it has to be that literally criminal kind of malpractice for your personal assets to ever actually be at risk. So that is not really a concern. And I hear that all the time. That's one of those playground rumors that goes around a lot, that I get older radiologists call and say, well, I'd love to keep working, but I'm just afraid that I'll get sued and someone will take my house. That's not going to happen. That really isn't. That's why medical malpractice insurance exists.
Are you familiar with that recent case that I believe it went to trial in New York State against a then resident? I think it's from like 2018 for a missed basilar occlusion, that for which I believe that the plaintiff was awarded something on the order of $120 million in Westchester County.
I mean, runaway verdicts, they do occur, and they occur in New York. Honestly, that has a lot to do with the state in which that happened, where you tend to get empathetic juries that are willing to give awards like that. The truth is that probably was never collected. Even when juries award vast sums like that, the reality is that that money is not available to them and most likely will never be paid. So while it's shocking and striking to see something like that, it rarely ever becomes anything more than, honestly, a policy limit demand.
Have you thought about how much the 21st Century Cures Act, that new piece of legislation, well, I guess it's not new now, but from a few years ago, where now all patients are able to access their radiology reports, they have to be given them, and how that change in reporting or a change in information exchange might change lawsuits, because now, there's this horror story case that I remember from a while ago when I was in New York, of this poor woman who had had a previous scan for appendicitis a few years before, but then got a new scan that and on that first scan, it was noted that there was something weird near the pancreas, in the distal portion of the pancreas, but it was never followed up on. She never got access to that information, and so then a couple years later, she comes back in with just the worst, distal pancreatic mass, invading the spleen, and And so I was wondering, after listening to your lecture and over the last few years, as the 21st Century Cures Act came in, like if she had been able to access, I don't know if that turned into a lawsuit or anything else about that case, but I don't know if if she had access and had been able to access her own information, if that would change who was liable in that case. Anyway, just your general thoughts on that.
Well, you would hope, honestly, that the outcome there is to avoid a devastating patient outcome, right? So I think it's a great idea that patients are given access to their records. And in that case, she might have read that and said, well, wait, what is this here? And gotten the follow-up that clearly her referring clinician had failed to spot and arrange. And that actually remind me as well of artificial intelligence, that now we're having algorithms actually spot cases. And radiologists come to me all the time and say, well, now I'm concerned that the AI says that I missed this. Am I going to be held responsible for that? And the bottom line is, anything in medicine that reduces the risk of a devastating outcome is desirable, because we go back to my 3 required elements of any med mal. You've got to have a radiologist's error, you've got to have a devastating outcome, and you've got to have an inattentive clinician. And I think that anything that reduces the risk of that devastating outcome dramatically reduces the risk of a medical malpractice suit. And so I think having access to that information is more likely to prevent devastating outcomes rather than implicate medical professionals. Certainly, there will be exceptions, right? They might spot something in a previous report that's inaccurate, and once they have a devastating outcome, hie back to that. But it's a lot less likely. I think if people are actively pouring through their medical records, they're much more likely to spot something that needs to be addressed and avert that devastating outcome.
Yeah, I completely. I mean, that's what I was thinking too. That it would reduce reduce worse outcomes and potentially reduce radiology liability.
Getting the right answer is always the answer. I say that is always desirable, right? I say that to radiologists all the time that say, well, I found out I missed this thing. Should I correct the record? Yeah, correct the record. And that's something that comes up a lot, because radiologists say, oh, you're simply acting as the plaintiff's expert witness by addending a report and saying, on further review, I have identified this finding. That doesn't happen. What does happen is the devastating outcome from that missed finding is averted by addending the report and getting the record corrected and getting that patient the appropriate follow-up or care that was indicated. And so we take a pretty firm line on that. I tell our radiologists, don't addend the report if the definitive treatment has already been given. All right, if they went in and took out that liver lesion, then of course it's no longer relevant. Don't addend a report if you know there is pending malpractice. Once a claim is filed, you don't want to be even opening that case and looking as though you're meddling in it. And an addendum at that point is never going to help you, right? And don't addend your report if the patient has died, because then the patient care issue is moot, to say the least. So those are the 3 exceptions to my rule, but generally speaking, almost no matter what kind of time frame we're talking about, correcting the medical record is the best way to avoid a devastating outcome, and it's the devastating outcome that's going to make that case convert to a medical malpractice.
We have just a couple quick rapid fire questions before we close up. The first one is, what is one important medical truth that very few of your colleagues agree with you on?
Well, I'll go back to that original, since we're on the med mal theme. I'll go back to that original statement I was making about communication. Those two cases that I cited, where those were the only two cases where there was just a failure to call the clinician with a critical finding. The radiology report described the finding. The radiologist had identified it, put it in the report, but just didn't call the clinician. Both of those cases were chest x-rays showing acute pneumonia. And so my advice from that, and I say it all the time in many venues, I say, you see lobar consolidation consistent with pneumonia in a patient who's in an urgent care or an ER, right? We're not talking about the left lower lobe atelectasis that happens to every ICU patient, et cetera. We're talking about you're making the initial diagnosis of lobar consolidation in an urgent care or emergency room patient. You call that clinician and tell them there's an acute pneumonia. And, that just gets groans in all the crowds I speak to. They say, oh, are you kidding? Come on, I'll be on the phone all day. But I absolutely stick to that. Now, it's got a bunch of qualifiers in there, right? I'm not talking about the atelectatic left lower lobe that you see in every inpatient, right? I'm talking about the initial diagnosis of lobar consolidation in an urgent care or an ER. You need to call that in and tell the clinician, verbally communicate one-on-one that patient has an acute pneumonia. And so I get a lot of pushback on that, but it's a firm rule with me, and it's one I repeat all the time.
If you had unlimited funds for either a randomized controlled trial or some type of empiric study, some topic you are curious about for which you feel like there's not enough good evidence, what are you going to fund?
That is a tough question. We don't do too much clinical research. And so big unanswered questions like that don't come up all that often for us. I guess the thing that's bothered me the most is why pancreatic carcinomas don't cause pancreatitis. But that's more something that's just bothered me for decades. But I guess that if I had to have a question answered for me, that's one that comes up all the time, right? How come a stone blocking the duct causes pancreatitis in a matter of minutes or hours, and yet you can have a giant tumor in the head of the pancreas and a huge dilated pancreatic duct and no inflammation whatsoever? In fact, that presents with painless jaundice, is the classic presentation of a pancreatic carcinoma. So that's one that's always bothered me, just the inconsistency of those presentations. I suppose to help me sleep at night, I don't know that that's going to improve the lot of humankind, but I would, that is the question I've always really hungered for, the answer I've always really hungered for, and no one has been able to satisfactorily answer for me.
Last rapid fire question. The radiology job market is very hot right now. Are fellowships overrated or underrated?
That is a very tough question, but I have a way to dodge it and answer it. If you do a fellowship, it should be something that you love. You should be doing that fellowship because of your passionate desire to pursue that particular type of imaging. I see too many residents ask the question, what fellowship should I do? What do people want? What will give me the most leverage in the job market, et cetera? And the answer is that's the worst way to pick your fellowship. If you do a fellowship, you may very well be doing more of that than anything else. And so it had better be something you truly love. I would say pick your fellowship or do a fellowship if you can't stand the thought of not doing a fellowship in a specific specialty. That should be what you base that decision on. I mean, you are really plotting a course for the next several decades in terms of the emphasis on the type of imaging you'll be reading. And so if someone comes along and says, boy, they're hiring neuro rads, you better do a neuro specialty, and you hate brain MRs, well, that's a pretty poor decision, right? So I see personal preference come up too infrequently in the selection of fellowships. And I think that should be the main thing that drives it. Job markets cycle like crazy. I've seen 2 full cycles from dearth to flush in the radiology job market over the last 2 decades. And to make your decision based on market dynamics or market parameters in the current time frame is a bad decision. It will change. It'll cycle up in 5 years and then back down in another 5 years. And that's what we've seen typically. And, I am actually seeing an escalation in this capacity demand mismatch that we have now. And I don't know that cycle is going to turn back down anytime soon. Just to put a little caveat on that. But the market is very dynamic. It's always cycling. And just because a fellowship is the hot ticket today doesn't mean it will do anything for you 10 years, 20 years down the road. But what will matter 10 or 20 years down the road is that you have chosen a fellowship in something you love to do, because that's what you'll be doing.
Ben, thank you so much for joining us on the External Medicine podcast. For our listeners who are just hearing your mellifluous voice and want to get in contact with you in some way, can you tell them where they should go on the internet to find more about you other than your fantastic YouTube series?
Yeah, you can go to vRad.com, and there is all kinds of communication information there. I actually lecture to residents very frequently, so you can actually schedule me to lecture to your residency. There are email addresses where you can get in touch with me on vrad.com. So I recommend that as the best place to pose any questions to me. Anything you write there will get to me on my email or be routed to our marketing and recruiting teams, and they can help schedule lectures and those sorts of things. So that's probably the best place to go.
Great. Excellent. Thank you so much. This has been really fun.
Podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution.
If you'd like to support us, subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.